Hello there. We were studying about acute pancreatitis, and we also compared acute pancreatitis with acute cholangitis. Let's just quickly go through that once again. We have a mnemonic for acute pancreatitis, that is get smashed. This is a mnemonic for the causes of acute pancreatitis. Get smashed, that is gallstones, ethanol, trauma, steroids, mumps, and other viruses such as Coxsackie B virus, and uh, autoimmune conditions such as polyarthritis nodosa and Ascaris infection as well. From A, we have both autoimmune and Ascaris infection. Then scorpion venom and hypertriglyceridemia, hyperchylomicronemia, hypercalcemia, and hypothermia. Then ERCP we have, and that is endoscopic retrograde cholangiopancreatography, that also can lead to acute pancreatitis. And in the end, we have drugs, certain drugs. So gallstones, ethanol, trauma, steroids, mumps, autoimmune conditions such as polyarthritis nodosa and Ascaris infection, then scorpion venom, hypertriglyceridemia, hyperchylomicronemia, hypercalcemia, and hypothermia. Then ERCP, that is endoscopic retrograde cholangiopancreatography, and drugs such as azathioprine, mesalazine, didanosine, furosemide, pentamidine, steroids, sodium valproate, and benroflumetazide. Benroflu methiazide. Okay, after this, we studied about certain clinical features of acute pancreatitis. These are sudden severe epigastric or central abdominal pain. There is sudden severe epigastric or central abdominal pain which is radiating to back, and sitting forward may relieve it. And second, vomiting is prominent. So both these features are important. Sudden severe epigastric pain or central abdominal pain which is radiating to back, and sitting forward helps in relieving it. Second, vomiting is prominent. Other features can be such as fever, tachycardia, jaundice, shock, rigid abdomen with local or general tenderness, periumbilical bruising, also called as Cullen sign. This is periumbilical bruising, also called as Cullen sign. So, apart from these two important features, that is sudden severe epigastric pain or central abdominal pain and vomiting, other features would be fever, tachycardia, jaundice, shock, rigid abdomen with generalized or localized tenderness, and Cullen sign. Cullen sign is periumbilical bruising. Okay, and the investigations include raised serum amylase level more than 1000 or more than 3 times normal limit. However, serum lipase levels are more sensitive and more specific. Second, CT scan with contrast enhancement may be diagnostic. So both these investigations, raised serum amylase levels more than 1000, more than 3 times the normal, and but serum lipase levels are more specific and more sensitive. Second is CT scan with contrast enhancement, which may be diagnostic. CT scan with contrast enhancement may be diagnostic. Now management. Management is done by resuscitation with IV fluids, IV analgesia, and nutritional support and IV antibiotics. Management is resuscitation with IV fluids, IV analgesia, nutritional support, that is parenteral feeding, and IV antibiotics in severe cases. Now, comparison between acute pancreatitis and acute cholangitis. In this, the pain is radiating straight through to the back, which is better on sitting up or leaning forward. And there is generalized abdominal tenderness with reduced bowel sounds. Whereas in acute cholangitis, there is fever, there is right upper quadrant abdominal pain and jaundice. In acute cholangitis, there is fever with right upper quadrant abdominal pain and jaundice. and there is hypotension and leukocytosis. So in acute pancreatitis, it would be suggested by pain radiating straight through to the back, better on sitting up position or leaning forward. And along with that, in acute pancreatitis, there will be generalized abdominal tenderness with reduced bowel sounds. Whereas in acute cholangitis, there will be fever with right upper quadrant abdominal pain and jaundice. There will be hypotension and leukocytosis. It is confirmed by elevated serum amylase and serum lipase levels. Lipase are more sensitive specific, and CT scan of pancreas. It is confirmed by ultrasound scan of gallbladder, biliary ducts, and blood culture. So this is a difference in the confirmation. It is confirmed by elevated serum amylase and lipase levels and CT scan of pancreas. Acute cholangitis is confirmed by ultrasound of gallbladder, ultrasound scan of lower abdomen. That is ultrasound scan of gallbladder and biliary ducts and blood culture. And there is fever, there is right upper quadrant abdominal pain, there is jaundice, hypotension, and leukocytosis. And it is confirmed by ultrasound scan of gallbladder, biliary ducts, and blood culture. Okay, so this was what we studied about acute pancreatitis, and now we'll go through certain differentials of abdominal pain. So, abdominal pain differentials. So, these are the different causes of abdominal pain. So, first we are studying about upper abdominal pain. In upper abdominal pain, we have acute pancreatitis, in which there is tender epigastrium pain radiating to the back. There is fever, vomiting, risk factors include gallstones and alcohol. Bending forwards provides temporary relief. So, this is about acute pancreatitis. Second, peptic ulcer. Now, peptic ulcer, there are reflux symptoms, and they may have melena. Third is biliary colic. In this, there is right upper quadrant pain with radiation to scapula. Secondary to gallstones, and there is no fever. Acute cholecystitis. Fourth one is acute cholecystitis. So this will include Murphy's sign. Murphy's sign is right upper quadrant pain, and Cullen's sign was periumbilical bruising. Cullen's sign is periumbilical bruising seen in acute pancreatitis. Sorry, yes, acute pancreatitis. Cullen's sign is seen, that is periumbilical bruising, whereas Murphy's sign is right upper quadrant pain, which can be seen in acute cholangitis as well, and and acute cholecystitis as well. Murphy's sign, acute cholangitis as well as acute cholecystitis. Anyway, we are studying about acute cholecystitis, so Murphy's sign will be there, that is right upper quadrant pain. Another one in acute cholecystitis will be fever, vomiting, raised white cell count, that is leukocytosis will be there. Yes, leukocytosis will be there, raised WBC count. Think of it as biliary colic but with fever. It is just like biliary colic but with fever. Like biliary colic with fever, because in biliary colic we don't have fever. In acute pancreatitis also we have fever. In cholangitis also we have fever. In cholecystitis also we have fever. In biliary colic we don't have fever. So acute cholecystitis is just like biliary colic with fever. Another one which we can write here is ascending cholangitis. Let's write it here only. Ascending cholangitis. Ascending cholangitis, we will have Charcot striate. Charcot's triad. And Charcot's triad will include fever, jaundice, and right upper quadrant pain. That is Murphy's sign. So Charcot's triad will be seen in acute cholangitis, and Charcot's triad includes what? It includes fever, jaundice, and right upper quadrant pain. That is Murphy's sign. So this is about upper abdominal pain. Let's now go through other abdominal pains. So talking about other abdominal pain. Other abdominal pain will include appendicitis. In appendicitis, we will have generalized pain prior to localizing to right lower quadrant. In appendicitis, we will have generalized pain before it get localized to right lower quadrant pain. There will be rebound tenderness, and then we also have fever. There is fever and rebound tenderness. Okay, then second is renal colic. Renal colic, it will have severe loin to groin pain. In renal colic, we will have severe loin to groin pain, loin to groin, diagonal pain. There is hematuria and may have history of previous renal stone. May have history of previous renal stones. Third is acute pyelonephritis. In acute pyelonephritis, we will have urinary symptoms. Acute pyelonephritis, we will have urinary symptoms like dysuria and increase frequency and urgency. Second, we can have unilateral loin pain, then fever and rigors. Fourth is ectopic pregnancy. In ectopic pregnancy, pregnancy, we will have right iliac fossa or left iliac fossa pain radiating to shoulders. Right iliac fossa or left iliac fossa pain radiating to shoulders in ectopic pregnancy. And women who has their last menstrual period more than 6 weeks ago. Last menstrual period more than 6 weeks ago. And in ectopic pregnancy, beta HCG will be positive. Beta HCG will be positive. Last menstrual period for more than 6 weeks ago, beta HCG is positive, and the pain in ectopic pregnancy will be right iliac fossa or left iliac fossa pain radiating to shoulders. Then fifth is ovarian torsion. In ovarian torsion, we will have severe pain at right iliac fossa or left iliac fossa. And they usually with history of and ovarian cyst seen on ultrasound previously. So there will be severe pain at right iliac fossa or left iliac fossa, and usually with history of an ovarian cyst seen on ultrasound previously. Along with this, other causes of other types of abdominal pain can be pelvic inflammatory disease. Pelvic inflammatory disease. So in this, we will have adnexal tenderness, we can have cervical excitation, fever, young female patient, and history of sexually transmitted infection. Another cause is bowel obstruction. In bowel obstruction, there will be constipation, vomiting, abdominal distension, and not passing flatus. Not passing flatus. Another cause is abdominal aortic aneurysm rupture. Abdominal aortic aneurysm rupture. In this, there will be in abdominal aortic aneurysm rupture, there will be severe pain at abdomen or back. Second, elderly gentleman. Third, hypotensive. severe pain at abdomen or back, elderly gentleman, and hypotensive. This is about abdominal aortic aneurysm rupture. Then mesenteric ischemia. And this we'll have mesenteric ischemia will have sudden onset of abdominal pain, systemically unwell, vomiting, and history of atrial fibrillation or history of hypotension secondary to MI, myocardial ischemia, not infarction. So in mesenteric ischemia, sudden onset of abdominal pain, systemically unwell, vomiting, history of atrial fibrillation or history of hypotension secondary to MI, myocardial ischemia. And the last cause here is diverticulitis. In diverticulitis, age is usually 50 to 70 years. There is left iliac fossa pain. In appendicitis, we have right lower quadrant pain. In diverticulitis, we will have left iliac fossa pain. There is nausea and vomiting. Fever, diarrhea or constipation. Then blood mixed with stools. And leukocytosis, raised white cell count. So these are the different causes of upper abdominal pain and other types of abdominal pain. So abdominal pain differentials: upper abdominal pain, acute pancreatitis. First, acute pancreatitis, there will be tender epigastrium, pain radiating to the back, fever, vomiting. Risk factors such as gallstones and alcohol. Bending forwards will provide temporary relief. Second, peptic ulcer. In peptic ulcer, there will be reflex symptoms and they may have melena because of the bleeding. Third, biliary colic. In biliary colic, there will be right upper quadrant pain. In biliary colic, there will be right upper quadrant pain with radiation to scapula, and it is secondary to gallstones, and there is no fever. And right upper quadrant pain radiating to scapula in this. Now, acute cholecystitis. In acute cholecystitis, there is Murphy's sign, that is right upper quadrant pain. There is fever, vomiting, leukocytosis. There is leukocytosis, raised WBC count, and it is just like biliary colic but with fever. Ascending cholangitis. In ascending cholangitis, we will have Charcot's triad. This Charcot's triad include fever, jaundice, and Murphy's sign, that is right upper quadrant pain. Okay, then other types of abdominal pain. Other abdominal pain differentials are Appendicitis. In appendicitis, there will be generalized pain before it gets localized to right lower quadrant. So first there is generalized pain before it gets localized to right lower quadrant. Then there is rebound tenderness. In First in appendicitis, we will have generalized pain before it get localized to right lower quadrant pain. There will be fever and rebound tenderness. Fever and rebound tenderness in appendicitis. Then renal colic. In renal colic, there will be severe loin to groin pain, and there will be hematuria, and they may have history of previous renal stones. So renal colic pain, severe loin to groin pain, hematuria, may have history of previous renal stones. Acute pyelonephritis. Acute pyelonephritis, there are urinary symptoms like in acute pyelonephritis, there are urinary symptoms like dysuria, increased frequency of micturition and urgency, unilateral loin pain, fever, and rigors. So, urinary acute pyelonephritis, we will have urinary symptoms like dysuria, increased frequency, urgency. There will be unilateral loin pain, fever, and rigors. In ectopic pregnancy, we will have right iliac fossa or left iliac fossa pain radiating to shoulders. Beta HCG will be positive. Last menstrual period more than 6 weeks ago. Okay, so here we'll have in ectopic pregnancy we'll have right iliac fossa or left iliac fossa pain radiating to shoulders, and last menstrual period is for more than 6 weeks ago. Beta HCG will be positive. In ovarian torsion, we'll have severe pain at right iliac fossa and or left iliac fossa. In ovarian torsion, we'll have severe pain at right iliac fossa or left iliac fossa, and they may have history of an ovarian cyst seen on ultrasound previously. So in ovarian torsion, severe pain at right iliac fossa or left iliac fossa, usually with history of an ovarian cyst seen on ultrasound previously. Now, other causes will be pelvic inflammatory disease, where we will have uh, adnexal tenderness. In pelvic inflammatory disease, we will have adnexal tenderness, cervical excitation, fever, young female, history of sexually transmitted infection. In pelvic inflammatory disease, we will have adnexal tenderness, cervical excitation, young female patient, there will be fever, history of sexually transmitted infection. This is pelvic inflammatory disease. Now, bowel obstruction, we will have constipation, vomiting, abdominal distension, and unable to pass flatus. Now, in abdominal aortic aneurysm rupture, there will be severe pain at abdomen or back, elderly gentleman, and hypotensive. Severe pain at the abdomen or back, elderly individual, and hypotensive. Mesenteric ischemia. In mesenteric ischemia, there is sudden onset of abdominal pain. Patient is systemically unwell. In mesenteric ischemia, there is sudden onset of abdominal pain and patient is systemically unwell. There is vomiting and history of atrial fibrillation or history of hypotension secondary to myocardial ischemia. So this is about mesenteric ischemia. Sudden onset of abdominal pain, systemically unwell, vomiting, history of atrial fibrillation or hypotension secondary to myocardial ischemia. Now, diverticulitis. In diverticulitis, age is 50 to 70 years. There is left iliac fossa pain, nausea and vomiting is there, fever, diarrhea or constipation, blood mixed with stools, leukocytosis. So these are the different features of diverticulitis. Age 50 to 70 years, left iliac fossa pain, nausea and vomiting, fever, diarrhea or constipation. There can be diarrhea or constipation, blood mixed with stools, and increased white cell count, that is leukocytosis. Now let's move further. Here, a 58-year-old man has been having frequent episodes of secretory diarrhea for the past 2 weeks. His diarrhea is extremely watery with large amounts of mucus. A diagnosis of villus adenoma was made after performing an endoscopy. What is the single most likely electrolyte abnormality in this? So a villus adenoma, here what we have to study here is about villus adenoma and its associated electrolyte abnormality. A villus adenoma secretes a mucus that is rich in protein and potassium. Protein and potassium. A blood test will therefore show hypoproteinemia and hypokalemia. So remember that villus adenoma is one of the causes of hypokalemia. So villus adenoma secretes mucus rich in protein and potassium. Villus adenoma secretes mucus rich in protein and potassium. Therefore, it causes hypoproteinemia and hypokalemia. So, villus adenoma is one of the causes of hypokalemia. So, villus adenoma secretes a mucus rich in protein and potassium, so there will be hypoproteinemia and hypokalemia. Therefore, we have to remember villus adenoma is one of the causes of hypokalemia. So, let's move further now. So now, here a 60 years old man presents with difficulty swallowing solids. He denies pain and weight loss. He boasts to you that he is in top physical shape and is still able to run half marathons faster than the kids that are less than half his age. He attributes this success to being a lifelong teetotaler, maintaining a healthy diet, and never having smoked a cigarette in his life. The patient cannot recall the last time he has needed to visit a doctor. Upon history taking, he admits that his clothes have been becoming looser over the past several months. He also admits to having heartburn and an acidic taste in his mouth while eating for as long as he can remember, but he thinks this is due to the speed at which he consumes his meals. So, what is the most appropriate investigation that will lead or that will help us to make a diagnosis in this case? So, here we have to understand this scenario and let's see about this. So, anytime we see dysphagia plus weight loss plus elderly, at the top of your differential diagnosis must be esophageal cancer. Consequently, the most appropriate diagnostic test would be upper GI endoscopy. So, whenever we see dysphagia plus weight loss plus elderly, so esophageal cancer must be at the top of the differentials. Esophageal cancer. Therefore, appropriate diagnostic test here, appropriate diagnostic test here will be upper GI endoscopy. Upper GI endoscopy. It is highly likely the patient has long-term untreated gastroesophageal reflux disease (GERD) which has led to esophageal cancer. The most accurate diagnostic test for GERD is 24-hour esophageal pH monitoring. But this is not the most appropriate test in this case as our primary concern is to rule out cancer. Our primary concern here is to rule out cancer. So GERD or GORD. So GERD or GORD, If it is left untreated for long, it can lead to esophageal cancer. And here, most accurate diagnostic test is 24 hours esophageal pH monitoring. Esophageal pH monitoring. But in this case, we have to rule out the cancer. The primary concern here is to rule out cancer. Therefore, this would not be the most appropriate test in this case. Other investigations or differential investigations which we can think here can be like manometry. It is the investigation of choice for motility disorders. And these motility disorders are for both solids and liquids. No discrimination. A CT scan is used for the staging of esophageal cancer, and CT scan is used for staging of esophageal cancer. So, upper GI endoscopy allows the visualization of internal lining of esophagus, stomach, and duodenum. And common indications include dyspepsia, unresponsive to medical treatment, dysphagia, urinoephagia, suspicion of bleeding or malignancy. Manometry is a medical procedure used to measure pressure at different points along the GI tract. It measures pressure along different points of GI tract. It involves insertion of a catheter containing pressure transducers into either mouth or anus. Procedure is typically used to assess for motility disorder within the GI tract once structural compromise has been ruled out. Catheter uh, containing pressure transducers via mouth or anus. So this is manometry, and upper GI endoscopy helps in visualization of interior lining. So, whenever a patient denies weight loss but you are suspicious of cancer, we must ask if they have noticed if their clothes have been becoming looser or anyone else has commented on them losing weight, because sometimes they are not in a mindset that they have actually lost some weight. So, whenever a patient denies any weight loss but we are suspicious of cancer, we can ask if they have noticed their clothes have been becoming looser recently, or anyone else has commented on them losing weight. So, anytime, let's just go through this once again. Anytime we see in the question dysphagia plus weight loss plus elderly, we on the top of differential diagnosis must be esophageal cancer. For esophageal cancer, a most appropriate diagnostic test is upper GI endoscopy. This upper GI endoscopy helps in visualization of the interior lining of the GI tract, that is esophagus, stomach, and duodenum. And this esophageal cancer, in this CT scan is used for staging of the esophageal cancer. Now, if GERD or GORD, that is gastroesophageal reflux disease, it is if it is left untreated for a long period of time, if the patient has long-term untreated gastroesophageal reflux disease, it can lead to esophageal cancer. And the most accurate diagnostic test for gastroesophageal reflux disease is 24-hour esophageal pH monitoring. 24-hour esophageal pH monitoring. But this is not the most appropriate test in this case, because our primary concern here is to rule out cancer. So upper GI endoscopy. Whereas esophageal manometry is the investigation of choice for motility disorders. Manometry is the investigation of choice for motility disorders. It involves measuring the pressure at different points of GIT. It involves inserting a catheter with pressure transducers through mouth or anus. And these motility disorders, they do not discriminate. These motility disorders are for both solids as well as liquids. So they do not discriminate. And if the patient denies weight loss and we are suspicious of cancer, we can ask about clothes becoming looser recently or anyone else commenting on the weight loss. Let's go further. Now we have a 40-year-old woman who is complaining of dysphagia when eating solids and drinking liquids, which has been worsening over the past year. She sometimes suffers from severe retrosternal chest pain. Barium swallow reveals a dilated esophagus which tapers to a fine distal end. What is the single most appropriate management in this case? So now we have to study about two things here. First is achalasia and second is dysphagia. Let's first study about achalasia. Achalasia is the idiopathic loss. Now, achalasia is the idiopathic loss of the normal neural structure of lower esophageal sphincter, which results in failure of relaxation of the circular muscles at the distal esophagus. The lower esophageal sphincter is usually contracted to prevent the acidic gastric contents from the reflux backwards into the esophagus. This is normally a relax there is normally a relaxation process of the lower esophageal sphincter during swallowing in order to allow food to pass into the stomach. In achalasia, there is loss of the ability to relax the lower esophageal sphincter. So achalasia, it is idiopathic loss of normal neural structure of lower esophageal sphincter resulting in failure of relaxation of the circular muscles at the distal end of esophagus. Lower esophageal sphincter is usually contracted to prevent reflux of acidic gastric contents backwards into the esophagus. And normally there is a relaxation process of lower esophageal sphincter while we swallow food to pass it into the stomach. Which is lost here. And in echalasia, there is loss of the ability to relax the lower esophageal sphincter, which is lost here. So in echalasia, there is loss of the ability, loss of ability to relax the lower esophageal sphincter. Now presentation. In presentation, there is progressive dysphagia to both solids and liquids simultaneously. In presentation, there is first there is progressive dysphagia to both solids and liquids simultaneously, and they can have regurgitation of stagnant food several hours after eating. Second, there is weight loss. Third, nighttime coughing fits due to aspiration can result in recurrent lower respiratory tract infections. And fourth, echalasia has no relationship with alcohol or tobacco use. So presentation. Progressive dysphagia to both solids and liquids simultaneously. And can have regurgitation of stagnant food several hours after eating. This occurs over years. Second, there will be weight loss. Third, nighttime coughing fits. Nighttime coughing fits which occur due to aspiration resulting in recurrent lower respiratory tract infections. Fourth is achalasia has no relationship with alcohol and tobacco use. Now, this is different from esophageal cancer, which not only usually presents with dysphagia to solid foods that progresses to difficulty in swallowing liquids, but also is more common in older patients with a long history of alcohol and tobacco use. So, what is the difference from esophageal cancer? In esophageal cancer, dysphagia to solid progresses to dysphagia to liquids. No, they don't occur simultaneously, not simultaneously. And second, they have history of alcohol and tobacco use. Long history of alcohol and tobacco use. In esophageal cancer, the dysphagia to solids will gradually progress to dysphagia to liquids, not simultaneously, like in achalasia cardia. And there is a long history of alcohol or tobacco use. Whereas in achalasia, there is no relationship with alcohol or tobacco use. Anyway, now talking about investigations. Investigations, most initial investigation will be endoscopy. Now, endoscopy will not diagnose achalasia, but it is needed for anyone with dysphagia to rule out cancer first. In medical school, many of you may have been taught that barium swallow would be the first investigation to perform prior to endoscopy as it is less invasive. Over the past few years, there has been a big switch where now endoscopies are performed first to rule out cancer for anyone with dysphagia. This goes in line with NICE guidelines and British Society of Gastroenterology for esophageal manometry and esophageal reflux monitoring, and as well as the European guidelines on achalasia, United European Gastroenterology, and European Society of Neurogastroenterology and Motility recommendations of 2020. So, most initial investigations would be endoscopy, not barium swallow. Changed recently. Most initial investigation would be endoscopy, not barium swallow. Done, it is done to rule out cancer first. Nice. CKS. Second is gold standard. Now, gold standard for achalasia is esophageal manometry. Esophageal manometry. It is the most accurate test overall. That is esophageal manometry, and manometry shows increased lower esophageal resting pressure. Gold standard test is, it is the most initial endoscopy, and the gold standard is esophageal manometry. It is the most accurate test for achalasia, and it shows increased lower esophageal resting pressure. Third investigation is barium swallow, only done if manometry is not available. Barium swallow, it shows dilation of the esophagus, which narrows into a bird's beak at the distal end. So barium swallow done if manometry not available. It shows bird's beak appearance. That is dilation of the esophagus, dilation of esophagus, narrowing at distal end. These are the investigations, and let's write management here itself. And the management will be dilatation of the lower esophageal sphincter. Management would be dilatation of lower esophageal sphincter. So this is about achalasia. Achalasia is the idiopathic loss of the normal neural structure of lower esophageal sphincter, which results in failure of relaxation of the circular muscles of the distal esophagus. The lower esophageal sphincter is usually contracted to prevent the reflux of acidic gastric contents back into the esophagus, but there is normally a relaxation process of lower esophageal sphincter during the time of swelling so as to allow food to pass into the stomach. But in achalasia, there is loss of this normal neural structure, the loss of this ability to relax the lower esophageal sphincter, due to which it is contracted. It remains contracted. There is failure of relaxation of the circular muscles of distal esophagus or lower esophageal sphincter. So it is contracted. Stenosis is there. Now, presentation in this, there is progressive dysphagia to both solids and liquids simultaneously. They can have regurgitation of stagnant food several hours after eating as well. There is weight loss, And there is nighttime coughing fits, which is due to aspiration, which can result in recurrent lower respiratory tract infections. And echinacea has got no relationship with alcohol and tobacco use. Echinacea has no relationship with alcohol or tobacco use. The difference from esophageal cancer is that in esophageal cancer, the dysphagia first there is dysphagia to solids, which further progresses to dysphagia to liquids as well. They are not simultaneous. And second, it is more common in older patients. It is more common in older patients with long history of alcohol and tobacco use. Older patients. More common in older patients with a long history of alcohol and tobacco use. Now, investigations. Most initial investigation done is endoscopy. This endoscopy will not just diagnose achalasia, but it is needed for anyone with dysphagia to rule out cancer first. So endoscopy is the most initial investigation. Endoscopy is done because it helps in ruling out cancer first. Earlier it was barium swallow, but now it has changed. And recently there has been a big switch now where endoscopies are performed first to rule out cancer for anyone with dysphagia, according to NICE guidelines and European guidelines. And the gold standard test here is esophageal manometry. Gold standard test for achalasia is esophageal manometry. It is the most accurate test overall for achalasia, esophageal manometry, and it shows increased lower esophageal resting pressure. Third is barium swallow. Barium swallow is done only if manometry is not available. Barium swallow will show bird's beak appearance. That is, it will show dilated esophagus narrowing into a bird's beak, narrowing into a contracted or constricted distal end. So barium swallow will show dilation of the esophagus, which narrows into a bird's beak at the distal end. Management is simply dilatation of the lower esophageal sphincter. So it is not barium swallow which is done first. It is the endoscopy which is done first, because first we have to rule out cancer. Earlier it was barium swallow. It has been changed recently. This is how it is practiced now. Now we'll study about dysphagia. So if there is dysphagia to both solids and liquids, this is most likely a motility problem, that is achalasia, scleroderma, or diffuse esophageal spasm. If there is dysphagia to both solids and liquids, then it is most likely a motility problem. And motility problem would be such as achalasia, scleroderma, and diffuse esophageal spasm. Diffuse esophageal spasm. Now, if the dysphagia is initially to solids but progresses to involve liquids as well. This is most likely a mechanical obstruction, that is esophageal cancer, esophageal ring, or peptic stricture. If there is dysphagia initially to solids but progresses to also involve liquids, then it is most likely mechanical obstruction. And mechanical obstruction can be due to esophageal cancer, esophageal ring, or peptic stricture. Once a distinction has been made between a motility problem and a mechanical obstruction, it is important to differentiate if the dysphagia is intermittent or progressive. So, after distinction, we have to find if dysphagia is intermittent or progressive. So, motility problem, intermittent motility dysphagia is due to diffuse esophageal spasm. Progressive motility dysphagia is due to achalasia or scleroderma. Mechanical obstruction, intermittent mechanical dysphagia is due to esophageal ring. Progressive mechanical dysphagia is due to peptic stricture or esophageal cancer. So, motility problem, uh, intermittent motility dysphagia is due to diffuse esophageal spasm, and progressive motility dysphagia is due to achalasia and scleroderma. Whereas mechanical obstruction intermittent mechanical dysphagia is due to esophageal ring. So in both the types, in intermittent, esophageal terms are there. This we can use to learn. Esophageal terms are there. Intermittent motility dysphagia, diffuse esophageal spasm. Progressive is achalasia and scleroderma. In intermittent mechanical dysphagia, there is esophageal ring. Although we will have esophageal cancer here as well in progressive. In progressive mechanical dysphagia, we will have uh, peptic stricture, peptic stricture, and esophageal cancer. So, investigations. Most patients with symptoms of dysphagia are referred for an endoscopy first to exclude out the cancer. Even patients with high suspicion of achalasia are first sent for an endoscopy to rule out cancer. The only situation that you would pick barium swallow as an initial investigation is the exam when you suspect a pharyngeal pouch. Endoscopies as the initial investigation for pharyngeal pouch holds the risk of perforating the lesion. So one important thing is only in case of pharyngeal pouch, barium swallow would be the first investigation. Only in pharyngeal pouch, barium swallow is the first investigation, not endoscopy, because of the risk of perforating the lesion. Because of the because of risk of perforating lesion. So this is all about dysphagia. Let's just quickly go through that. Dysphagia, if there is dysphagia to both solids and liquids simultaneously, then it is a motility problem, which are achalasia, scleroderma, and diffuse esophageal spasm. But if there is dysphagia initially to solids, but later on it progresses to dysphagia to liquids as well, then it is a mechanical obstruction, which can be esophageal cancer, it can be esophageal ring, peptic stricture. So these esophageal ring, peptic stricture, and esophageal cancer. Mechanical obstruction, esophageal cancer, esophageal ring, and peptic stricture. After distinction, we have to find whether the dysphagia is intermittent or progressive. So in motility problems, if in intermittent motility dysphagia is due to diffuse esophageal spasm, progressive motility dysphagia is due to achalasia and scleroderma, intermittent mechanical dysphagia is due to esophageal ring, progressive mechanical dysphagia is due to esophageal cancer and peptic stricture. In all the case of dysphagia, always endoscopy has to be done first to exclude cancer, even with the patients of high suspicion of achalasia. Although in achalasia, esophageal monitoring, esophageal manometry is gold standard. But even in those cases of achalasia, endoscopy is done to rule out cancer first. The only situation where barium swallow is the initial investigation is when we suspect a pharyngeal pouch. A pharyngeal pouch. Only in pharyngeal pouch, barium swallow would be the first investigation because endoscopy can increase the risk of perforating the lesion, can cause perforation of the lesion as the initial investigation for pharyngeal pouch. Okay, so now let's move further. Now, here a 70-year-old woman is reviewed following a course of oral clindamycin for right lower limb cellulitis. She was initially admitted in the hospital for 3 days for the management of her cellulitis as she was unable to wait beer. She was unable to wait beer She was discharged 2 days ago and quickly developed bloody diarrhea and abdominal pain. She has a temperature of 38.8 degrees Celsius. Her blood tests show hemoglobin 125, white blood cell count 18, and CRP is 160. What is the single most likely management in this case? So here, white cell count is raised, CRP is also raised. So they are asking about the single most likely management in this case. So here we have to study about Clostridium difficile. So one more thing about barium swallow. Barium swallow shows narrowing to the distal end of the esophagus, which is sometimes described as bird's beak. It is seen in achalasia, and dilatation of sphincter is a treatment. Just a small thing which we missed. Anyway, so talking about Clostridium difficile now. Clostridium difficile is a gram-positive rod often encountered in hospital practice. It is transmitted via fecal-oral route by spores which are resistant to antibiotics. It produces an exotoxin which causes intestinal damage, leading to a syndrome called pseudomembranous colitis. Clostridium difficile develops when the normal gut flora is suppressed by broad spectrum antibiotics. So it causes pseudomembranous colitis. So Clostridium difficile is a gram-positive rod often encountered in hospitals. It is transmitted by fecal oral route by spores which are resistant to antibiotics. Transmitted by fecal oral route by spores which are resistant to antibiotics. Clostridium difficile produces an exotoxin which causes intestinal damage, leading to a syndrome called pseudomembranous colitis. It produces an exotoxin which causes intestinal damage, leading to a syndrome called pseudomembranous colitis. Clostridium difficile develops when the normal gut Clostridium difficile develops when normal gut flora is suppressed by the broad spectrum antibiotics. Most common antibiotics implicated in Clostridium difficile infections are most common antibiotics implicated in Clostridium difficile infections are clindamycin, cephalosporins, particularly second and third generation, quinolones, coamoxiclav, aminopenicillins. Amoxicillin and ampicillin. So clindamycin, most common antibiotics are clindamycin, cephalosporins, second and third generation, quinolones, coamoxiclav, and aminopenicillins such as amoxicillin and ampicillin. Okay, now features. Features can have features can be like diarrhea, mild or serious bloody type, abdominal pain, raised white cell count, and fever. So these are the features. Diagnosis. Clostridium difficile toxin, that is CDT, detected in the stool. Clostridium difficile toxin, Clostridium difficile toxin, that is CDT, detected in the stool. That is diagnosis. Now management. First, stop the causative antibiotic if possible. Which allows the normal intestinal flora to get re-established, which allows normal gut flora to re-establish. So first is this in the management. Second step would be first line therapy of oral vancomycin. If not responding to oral vancomycin, then oral fidaxomicin. Oral fidaxomicin. If both are ineffective, then oral vancomycin plus minus oral metronidazole. So vancomycin, metronidazole, and fidaxomicin are used in the management of Clostridium difficile. Another method of treating Clostridium difficile is fecal microbial transplantation, but we shall not discuss this here right now. Another method here is fecal microbial transplantation. Treatment is usually not needed if the patient is asymptomatic. So let's go through Clostridium difficile. Once again, first, Clostridium difficile is a gram-positive rod which is often encountered in hospital practice. It is transmitted by fecal-oral route by the spores which are resistant to antibiotics. It produces an exotoxin which causes intestinal damage, leading to a syndrome called pseudomembranous colitis. Clostridium difficile develops when the normal gut flora is suppressed by the broad spectrum antibiotics. Most common antibiotics which are implicated in Clostridium difficile infections are clindamycin, clindamycin first, then cephalosporin second and third generation, quinolones, coamoxiclav, then aminopenicillins such as amoxicillin and ampicillin. Aminopenicillins such as amoxicillin and ampicillin. Clindamycin, cephalosporins, quinolones, coamoxiclav, and aminopenicillins, amoxicillin, and ampicillin. Features of Clostridium difficile: there is diarrhea, which can be mild or serious bloody type. Abdominal pain can be very severe sometimes. Raised white cell count, raised white blood cell count, and fever. So there is diarrhea, abdominal pain, raised white blood cell count, and fever. Diagnosis is by Clostridium difficile toxin detected in the stool. CDT or Clostridium difficile toxin detected in the stool. Management is, first we have to stop the causative antibiotic if possible, which allows normal gut flora to get reestablished. Then first line therapy by oral vancomycin. If not responding to oral vancomycin, then fidaxomicin. If both are ineffective, not responding to vancomycin or fidaxomicin, then we have to give oral vancomycin plus minus oral metronidazole. So metronidazole, vancomycin, and fidaxomicin. Vancomycin, fidaxomicin and metronidazole. These are used in the treatment of Clostridium difficile. Another method is fecal microbial transplantation, which is also used for treating Clostridium difficile. Fecal microbial transplant, but treatment is not required if the patient is asymptomatic. So the scenario here shows a classical picture of Clostridium difficile, of which oral vancomycin is the first line. The previous antibiotic choice for Clostridium difficile was oral metronidazole, but there has been a change in the guidelines. So now microbiologists are recommending oral vancomycin as the first line antibiotic for Clostridium difficile. If it is not effective, then fidaxomicin. If both are ineffective, then oral vancomycin plus minus oral metronidazole. The two risk factors here are clindamycin, increased risk of Clostridium difficile infections. Recently been in hospital, so the patient may have picked up Clostridium difficile. Clindamycin was given to the patient. Oral clindamycin was given, which increases the risk of Clostridium difficile infection, and recently been in hospital, so she may have picked up Clostridium difficile. So we have to look out for antibiotic usage like clindamycin, then cephalosporin second and third generation, or quinolones, comoxiclav, and aminopenicillins like amoxicillin and ampicillin as a cause, because these are implicated for Clostridium difficile infections, cause of Clostridium difficile infections. Okay, so now let's move further now. So now here we have a 56-year-old woman who has had severe abdominal pain for 24 hours, radiating to her back, accompanied by nausea and vomiting. She denies any diarrhea or fever. She appears to be tachycardiac and in shock. She has history of gallstones. What is the single most likely investigation to confirm the diagnosis in this case? So, patient here seems to be a case of acute pancreatitis. Which we have already studied about. The most likely diagnosis is acute pancreatitis, and the most useful investigation is serum lipase, looking for an elevation of more than 3 times the upper limit of normal. Serum lipase is more sensitive and more specific than serum amylase level, although serum amylase levels are also high, and CT scan of pancreas can also be used for diagnosis. So while abdominal x-rays are not useful in the diagnosis of pancreatitis, they are routinely ordered to exclude out other potential causes of abdominal pain such as perforation or bowel obstruction. Ultrasound is a useful method to detect the presence of gallstones, but it is not good diagnostic test for acute pancreatitis. Pancreas is poorly visualized in such cases, like 50% of the cases. Urea electrolytes and liver function tests do not directly aid the diagnosis of pancreatitis. They are helpful in assessing the severity of the disease by showing the degree of leukocytosis or hypovolemia, or giving clues to the etiology of pancreatitis, such as gallstone pancreatitis, but they are not used for diagnosis. So we'll carry out serum lipase here. The gold standard investigation for acute pancreatitis is exploratory laparotomy with histology of pancreas. There is sudden severe epigastric or central abdominal pain radiating to back, sitting forward may relieve it, vomiting is present. There can be tachycardia, fever, jaundice, shock, rigid abdomen with localized or generalized tenderness, then Cullen's sign or periumbilical bruising. Raised serum amylase level more than 3 times the normal or more than 1000. However, lipase levels are more sensitive, more specific. CT scan can be done. Resuscitated with IV fluids, IV analgesia, resuscitated with IV fluids, IV analgesia, nutritional support, parenteral feeding, IV antibiotics. Then the mnemonic gets smashed, that is gallstones, ethanol for etiology of acute pancreatitis, get smashed, gallstones, ethanol, trauma, steroids, mumps, and Coxsackie virus B, and then autoimmune conditions such as polyarthritis nodosa and Ascaris infection, then scorpion venom, hypertriglyceridemia, hyperchylomicronemia, hypercalcemia, hypothermia, then ERCP or endoscopic retrograde cholangiopancreatography, and certain drugs such as azathioprine, mesalazine, bendroflumethiazide, furosemide, pentamidine, steroid, sodium valproate. Anyway, let's move further. So now a 22-year-old man presents with a 2-month history of diarrhea. He says his bowels have not been right for the past few months. He frequently has to run to the toilet. These symptoms seem to be improving up until 2 weeks ago, and for the past week he notices the presence of even blood when he passes stool. On examination, there are aphthous oral ulcers. He has not lost any weight, has a good appetite. Examination of his abdomen demonstrates mild tenderness in the left lower quadrant, but no guarding. So abdominal examination demonstrates mild tenderness in the left lower quadrant but no guarding. So what is the single most likely diagnosis here? So as a patient, this is mostly a case of ulcerative colitis, and we have to note that while aphthous ulcers are more prevalent in Crohn's disease, they do still occur in ulcerative colitis. The bloody diarrhea and left-sided abdominal pain. The bloody diarrhea and left-sided abdominal pain are more suggestive of ulcerative colitis, but they can occur in Crohn's disease. Examination contains certain vague questions, and we must be able to weigh up possibilities and choose the most likely diagnosis. So definitive diagnosis would require utilization of endoscopy here. So it is important to know the differences between ulcerative colitis and Crohn's disease. In Crohn's disease, they can affect any part of the GI tract from mouth to anus. Okay. Crohn's disease usually non-bloody diarrhea, then abdominal mass palpable in right iliac fossa, increased goblet cells and increased granulomas on histology. Weight loss is more prominent, and then there are Crohn's disease is transmural. There are skip lesions and cobblestone appearance on endoscopy. transmural, skip lesions, and cobblestone appearance on endoscopy. Now coming to ulcerative colitis, it affects the mucous membrane starting from rectum. Ulcerative colitis affects the mucous membrane starting from rectum. There is bloody diarrhea, which is more common as compared to Crohn's disease. Abdominal pain in left lower quadrant. In Crohn's disease, abdominal mass is palpable in right iliac fossa. Here, there is abdominal pain in left lower quadrant. There is decreased goblet cells and decreased granulomas on histology. Primary sclerosing cholangitis is more common. Then in ulcerative colitis, there is loss of hostrations, drain pipe colon seen on barium enema. So in this there is loss of hostrations, drain pipe colon seen on barium enema. Once again, Crohn's disease, it can affect any part of the GI tract from mouth to anus. Usually non-bloody diarrhea, abdominal mass palpable in right iliac fossa, increase goblet cells and granulomas on histology, weight loss more prominent, transmural, skip lesions, and cobblestone appearance on endoscopy. Ulcerative colitis affects the mucous membrane starting from rectum. Bloody diarrhea more common compared to Crohn's disease. Abdominal pain in the left lower quadrant. Abdominal pain in the left lower quadrant. Decreased goblet cell, decreased granulomas on histology, primary sclerosing cholangitis, loss of hostrations and drain pipe colon seen on barium enema. Loss of hostrations and drain pipe colon seen on barium enema. Okay, let's move further now. Okay, so let's take a break for a while. I'll be back. Okay, so now we have here a 51-year-old man who has become increasingly fatigued over the past 10 months. His medical history includes having having a gastrectomy 1 year ago. Physical examination is unremarkable. Blood tests show hemoglobin 85, white cell count 7, platelets 240, mean cell volume 129. Now, the single most likely finding on blood smear. Now, this is a case of vitamin B12 deficiency. So, these findings, together with a history of gastric resection whereby malabsorption of vitamin B12 could occur, point towards the diagnosis of B12 deficiency. Mean cell volume is also increased, which supports the diagnosis. Hypersegmented neutrophils are seen on blood smear in megaloblastic anemia. So here it's about vitamin B12 deficiency. As we studied, vitamin B12 is found in meat, fish, and dairy products, not in plants. B12 then binds to intrinsic factor in the stomach, and this complex is then absorbed in the terminal ileum. Clinical presentation. Symptoms are those of chronic anemia. There can be fatigue, dyspnea on exertion. Neurological symptoms may also be present, such as classically peripheral paresthesia and disturbances of position and vibration sense. If uncorrected, patient may develop subacute combined degeneration of spinal cord leading to permanent ataxia. Causes of B12 deficiency. It can be pernicious anemia, which is the commonest cause. Due to autoimmune gastric atrophy resulting in loss of caseal intrinsic factor production required for absorption of B12. Pernicious anemia is the commonest cause, and due to autoimmune gastric atrophy resulting in loss of caseal intrinsic factor, which is required for absorption of vitamin B12. It's usually associated with other autoimmune problems such as hypothyroidism. Dietary causes can be such as vegan diet, and it can also occur due to following total gastrectomy, because body stores can last a few years. Gastrectomy will cause depletion of cobalamin stores. Then ileal disease can also cause, such as resection of ileum or Crohn's disease. Then malabsorption disorders such as celiac disease or tropical sprue. So these are the causes. Pernicious anemia, dietary causes such as vegan diet, total gastrectomy, ileal disease such as resection of ileum or Crohn's disease, malabsorption disorders like celiac disease or tropical sprue. Pernicious anemia is the commonest cause of vitamin B12 deficiency. Due to autoimmune gastric atrophy, there is loss of caseal intrinsic factor which is required for absorption of vitamin B12. And associated with other autoimmune problems like hypothyroidism. Now, hematological abnormalities of B12 deficiency are macrocytic anemia, and MCV is usually more than 110. There are hypersegmented neutrophils. Serum B12 is low. Homocysteine. Now, macrocytic anemia and MCV is usually more than 110. Hypersegmented neutrophils. These are both seen in folate deficiency as well as vitamin B12 deficiency. Serum B12 is low. Homocysteine. Now, deficiency of cobalamin results in elevation of plasma total homocysteine, not specific to cobalamin deficiency, as concentration of plasma total homocysteine are also elevated in folate deficiency. So, homocysteine levels would be high due to deficiency of cobalamin, which is also high in folate deficiency. It is a supplementary test where there is an indeterminate serum B12 level. Management is hydroxycobalamin intramuscularly. B12 deficiency management is hydroxycobalamin intramuscularly. It's found in meat, fish, and dairy products, not in plants. Now, comparison of B12 and folate was pernicious anemia in B12 deficiency due to malabsorption, and folate deficiency, poor bioavailability. Medical conditions in B12 deficiency: such as celiac disease, tropical sprue, and Crohn's disease, and gastric resection. And in folate deficiency, inflammation of small intestine, celiac disease, tropical sprue, and Crohn's disease. Low intake of cobalamin rich foods in B12 deficiency, and folate deficiency, low intake of folate rich foods, usually vegetables. So, fruits and vegetables, folate deficiency, because low intake of it is usually found in vegetables, folate. So, fruits and vegetables will give us folate, and beef and bacon, that is meat, fish, and dairy products, will give us B12. Hematological findings would be macrocytic anemia, MCV is high, more than 110, hypersegmented neutrophils, then low homocysteine levels, high homocysteine levels. All these things, so due to deficiency of cobalamin, all these things are seen in both vitamin B12 deficiency as well as folate deficiency. Okay, let's move further now. Now, a 54-year-old man presents with worsening history of intermittent dysphagia over a period of 6 months. He has not experienced any weight loss and complains of sometimes regurgitating food, after which he says he experiences a feeling of great relief. He has a history of recurrent respiratory tract infections over the past few years. He is a non smoker. So this is a case of achalasia. Note that in achalasia, the symptoms can also be intermittent, although we studied that it is a cause of progressive motility dysphagia. It can be intermittent as well. It usually presents with gradually progressive intermittent dysphagia. Gradually progressive intermittent dysphagia. The dysphagia associated with esophageal carcinoma is that is more that is mechanical in nature, and it is more rapid than achalasia. In achalasia, they may have a history of recurrent respiratory tract infections due to aspiration caused by regurgitation. Okay, let's move further. So, a 72-year-old man has been having loose stools over the past 5 weeks. He has noticed blood in his stool on several occasions. He has mild generalized abdominal pain most times of the day. On examination, his blood pressure is 130/80, heart rate is 80, temperature is 38.1. Abdominal examination reveals generalized tenderness without any palpable mass. A digital rectal examination is unremarkable. What is the single most appropriate initial investigation in this case? So here we have to study about colonoscopy, bowel cancer, and flexible sigmoidoscopy to a certain extent. So in this case, the single most appropriate initial investigation would be stool microscopy, culture, and sensitivity. Colonoscopy has no role in the acute setting. Common things are common. We mean one should investigate for bacteria causing gastroenteritis first, even though there is a long history of diarrhea. So there are certain things which we need to note down here. First, colonoscopy has no role in the acute setting. So one should investigate for bacteria causing gastroenteritis first, even though there is a long history of diarrhea. Bowel cancer can also be on the list of differentials and it can also present with fever. However, one should investigate for an infection prior to performing colonoscopy. There is a risk of bowel perforation with colonoscopy if an infection is present. In the acute setting, some may go to the extent of requesting an abdominal x-ray to rule out toxic megacolon if the patient has high fever, abdominal pain, and diarrhea. Flexible sigmoidoscopy are appropriate if considering inflammatory bowel disease or lower bowel cancers, which may be causing bleeding or diarrhea. It is not the most appropriate initial investigation. So, initial investigation for an infection is more important and should be done prior to colonoscopy. Because if infection is present, then there is a risk of bowel perforation with colonoscopy. Therefore, stool microscopy, culture, and sensitivity is done first. And to rule out toxic megacolon, abdominal x-ray can be advised. Toxic megacolon patient will have, if the patient is having high fever, abdominal pain, and diarrhea. Flexible sigmoidoscopy is appropriate if considering inflammatory bowel disease or lower bowel cancers. For inflammatory bowel disease or lower bowel cancers, should carry out flexible sigmoidoscopy. But it is not the most appropriate initial investigation. Most appropriate initial investigation is to work up for infection, that is stool microscopy culture and sensitivity. So what we have to take care here is that colonoscopy has no role in the acute setting. First, we should investigate for the bacteria causing gastroenteritis, even though there is a long history of diarrhea. So, bowel cancer can also be on the list of differential as it can also present with fever, but we should first investigate for the infection prior to performing a colonoscopy. Because if infection is present, then there is a risk of bowel perforation while carrying out colonoscopy if infection is there. In the acute setting, colonoscopy has no role. In the acute setting, mm, to uh, to rule out toxic megacolon, we can go for abdominal x-ray if the patient is having high fever, abdominal pain and diarrhea. And in case of inflammatory bowel disease or lower bowel cancers, you can carry out flexible sigmoidoscopy, but it is not the most appropriate initial investigation. The most appropriate initial investigation is to investigate for the infection and to find out or investigate for the bacteria causing gastroenteritis. So, most appropriate initial investigation would be stool microscopy and culture and sensitivity. Stool microscopy, culture, and sensitivity is the most appropriate initial investigations. So, we have to first work up or carry out investigation to find out the cause of infection, which is more important, should be done before colonoscopy. Because if infection is present, then there is a risk of bowel perforation with colonoscopy. For toxic megacolon, abdominal x-ray can be advised. For inflammatory bowel disease and lower bowel cancer, we can advise flexible sigmoidoscopy. Video fluoroscopy allows an x-ray examination of a swallow in real time. It utilizes barium containing food and fluid which are radio opaque, allows speech and language therapists a detailed analysis of swallow function, whether fluid food or fluid was being aspirated or not. Okay, let's move further. Now, a 60-year-old man presents with weight loss and complains of mild abdominal pain, bloating, and diarrhea for last 6 months. A recent blood test shows a hemoglobin of 7 gram per deciliter. What is the single most appropriate investigation which we have to carry out in this case? There is weight loss, there is mild abdominal pain, bloating, and diarrhea for last 6 months, and hemoglobin is 7. So in this case, we have to read about colonoscopy and colorectal carcinoma diagnosis. So colonoscopy would be able to diagnose majority of the causes of change of bowel habits and weight loss. The likely diagnosis here is colorectal cancer. Although inflammatory bowel disease can also be present with similar features such as weight loss, abdominal pain, anemia, whatever the cause is, a colonoscopy and biopsy is a gold standard to give us a diagnosis. So colonoscopy is able to diagnose majority of the causes of change of bowel habits and weight loss. So colonoscopy and biopsy, these are gold standard to give us diagnosis. Now we'll study about colorectal carcinoma diagnosis. Colorectal carcinoma diagnosis. Colonoscopy is the preferred diagnostic investigation, and alternatives to colonoscopy include barium enema and CT colonography. Colonoscopy is the preferred diagnostic investigation. Alternatives are barium enema and CT colonography. If a patient is without major comorbidities, colonoscopy should be preferred to diagnose colorectal cancer. If a lesion suspicious of cancer is detected, biopsy sample should be sent for histology. Patient is without major comorbidities, then colonoscopy is offered to diagnose colorectal cancer. If lesion is detected, biopsy sample. Biopsy is done or biopsy sample sent for histology. Sent for histology. Flexible sigmoidoscopy, then barium enema can be used as an alternative to colonoscopy for patients with major comorbidities. If patient is with major comorbidities, then flexible sigmoidoscopy and barium enema can be used. Barium enema may also be used if colonoscopy fails to visualize the cecum or if the patient is unable to tolerate the colonoscopy procedure. Barium enema also used if colonoscopy fails to visualize cecum or patient unable to tolerate colonoscopy. CT colonography can also be used as an alternative if the local radiology service can demonstrate competency in this technique. If a lesion suspicious of cancer is detected on CT colonography, a colonoscopy with biopsy can be used to confirm. CT colonography can also be used if radiology services are competent. After this, colonoscopy and biopsy are used to confirm. The tumor marker carcinoembryonic antigen CEA is of no use for diagnosis or staging, but it can be used to monitor disease relapse if raised at diagnosis and falls to normal after resection. Carcinoembryonic antigen is used to monitor disease relapse if raised at diagnosis and normal after resection, but not used for diagnosis or staging. So these are the things which we have to keep in mind about colorectal carcinoma diagnosis. First, colonoscopy is able to diagnose majority of the causes of change of bowel habits and weight loss. It is able to diagnose majority of the causes of changing of the bowel habits and weight loss. Colonoscopy and biopsy are gold standard. Colonoscopy carcinoma diagnosis. Colonoscopy is a preferred diagnostic investigations. So in colorectal carcinoma diagnosis, colonoscopy is the preferred diagnostic investigation. Alternatives can be barium enema or CT colonography. If patient is without any major comorbidities, then colonoscopy is preferred to diagnose the colorectal cancer. Then further, if the lesion is direct, biopsy is used to confirm the diagnosis, sent for histology and everything. If the patient is having major comorbidities, then instead of colonoscopy, we will use barium enema and flexible sigmoidoscopy. Alternatives used are barium enema and flexible sigmoidoscopy. Barium enema is also used if colonoscopy is unable to visualize cecum or patient is unable to tolerate the procedure of colonoscopy. CT colonography can also be used if radiology services are competent enough, and further colonoscopy and biopsy can be used to confirm the diagnosis. Now CEA, that is carcinoembryonic antigen, it is not used for diagnosis or staging. It is actually used to monitor the relapse of the disease if it is raised at the time of diagnosis and normal after resection. So this is about colonoscopy and colorectal carcinoma diagnosis. Now let's move further. A 65-year-old lady had urinary tract infection which was treated with a 7-day course of broad spectrum antibiotics. Few days later, she developed bloody diarrhea, severe abdominal pain. She has a temperature of 38.6 degrees Celsius, pulse rate 90, her blood test hemoglobin is 119, white cell count is 18, CRP is 180. So, single most likely management. So, this seems to be a case of pseudomembranous colitis. This scenario shows a classical picture of pseudomembranous colitis caused by Clostridium difficile. Broad spectrum antibiotics always have the potential to kill off the normal gut flora, therefore increasing the chances of Clostridium difficile to grow, and which causes further pseudomembranous colitis. Vancomycin is the first line drug which is used to manage Clostridium difficile. The previous antibiotic choice was metronidazole, but now it is oral vancomycin. Many patients want a strong antibiotic to treat their urinary tract infections, but they are not aware that such antibiotics such as cephalosporins, amoxicillin, these are broad spectrum, are commonly implicated in Clostridium difficile infections. Therefore, there is a very good reason why we should always start off with a narrow spectrum antibiotic such as trimethoprim and nitrofurantoin for simple urinary tract infections. We have to first remember all those antibiotics, broad spectrum antibiotics, which are implicated for Clostridium difficile infection, that is, which further leads to pseudomembranous colitis. And these antibiotics include clindamycin, cephalosporins, second and third generation quinolones, comoxiclav, aminopenicillin such as amoxicillin and ampicillin. And how we treat? First, we have to stop the antibiotic which is causing in order to let the gut flora reestablish. Then first line oral vancomycin. If patient is not responding to oral vancomycin, then we have to give oral fidaxomicin. If both are ineffective, then we have to give oral vancomycin plus minus oral metronidazole. So one thing which we have here, we should start with narrow spectrum antibiotics like trimethoprim and nitrofurantoin for simple urinary tract Actions to prevent Clostridium difficile infection resulting from damage to gut flora by broad spectrum antibiotics. Okay, let's move further. So, a 28-year-old female presents with 1 week history of jaundice, fever, and malaise. She was diagnosed with hypothyroidism for which she is receiving levothyroxine. Her blood tests show serum bilirubin 40, ALT 120, AST 90, ALP 200, prothrombin time 25. What is the single most likely diagnosis? So here we have to study about autoimmune hepatitis. So autoimmune hepatitis, it is a chronic disease of unknown cause characterized by continuing hepatocellular inflammation and necrosis which tends to progress to cirrhosis. It is a chronic disease of unknown cause characterized by continuous hepatocellular inflammation and necrosis which tends to progress to cirrhosis. It predominantly affects young or middle-aged women. Young or middle-aged women, and up to 40% present with acute hepatitis and signs of autoimmune disease. 40% presents with acute hepatitis and signs of autoimmune disease that can be like fever, malaise, urticarial rash, polyarthritis, pleurisy, pulmonary infiltration, or glomerulonephritis. The remainder present with gradual jaundice or are asymptomatic and diagnosed incidentally with signs of chronic liver disease. There can be gradual jaundice and signs of chronic liver disease. Amenorrhea is common and disease tends to attenuate during pregnancy. Amenorrhea is common and disease tends to attenuate during pregnancy. Now, investigations. Diagnosis rests on a combination of compatible biochemical, immunological, histological features together with exclusion of other liver diseases. So, investigation is based on combination of compatible biochemical, immunological, and histological features together with exclusion of liver diseases. Associated diseases, concurrent autoimmune disorders occur in 40% of the patients, particularly autoimmune thyroid disorders. Associated diseases, 40%. So here we studied about autoimmune hepatitis, and autoimmune hepatitis, let's just go through that. Autoimmune hepatitis is a chronic disease. Autoimmune hepatitis is a chronic disease of unknown cause, characterized by continuing hepatocellular inflammation and necrosis, which tends to progress to cirrhosis. Mainly affects young or middle-aged women. Up to 40% of the patient present with acute hepatitis and signs of autoimmune disease such as fever, malaise, urticarial rashes, polyarthritis, pleurisy, pulmonary infiltration, or glomerulonephritis. Others can present with gradual jaundice or asymptomatic. They can be diagnosed incidentally with signs of chronic liver disease. Amenorrhea is common. Disease tends to attenuate during pregnancy. Investigation is by combination of compatible biochemical, immunological, and histological features together with exclusion of other liver diseases. Associated diseases. Concurrent autoimmune disorders can occur in 40% of the patients, particularly autoimmune thyroid disorders. So, in autoimmune hepatitis, serum ALT, AST will be raised initially. Serum alkaline phosphatase is either normal or mildly raised. More than 2 times elevation would suggest alternative or additional diagnosis. Hypoalbuminemia and prolongation of prothrombin indicates dysfunction of hepatic synthetic function. Severe hepatic synthetic dysfunction. So lab tests do not rule out other liver diseases, but the combination of the presence of other autoimmune disease like hypothyroidism and all these other features of hepatic dysfunction, it most likely indicates or points towards autoimmune hepatitis, because hypothyroidism is also present and signs of liver dysfunction are also there. uh, all the indicators of liver dysfunction, so it indicates towards points towards autoimmune hepatitis. Affects young or middle-aged women. Continuing hepatocellular inflammation necrosis tends to progress to cirrhosis. Young or middle-aged women, 40% with acute hepatitis, signs of autoimmune disease such as fever, malaise, urticarial rash, polyarthritis, pleurisy, pulmonary infiltration, glomerulonephritis. Can be others can have jaundice or asymptomatic, can have signs of chronic liver disease. Amenorrhea is common. Disease attenuate during pregnancy. Autoimmune thyroid disorders can be associated. So that's it for this session, and we'll continue further uh, in other sessions. Till then, take care of yourself.